Hello students, myself Dr. A. Udhayan, Assistant Professor from the Department of Orthodontics, Vinayaka Mission Shankaracharya Dental College. I am here to present the topic on biology of tooth movement. Biology of tooth movement. It is the most crucial and very critical part of understanding the orthodontic tooth movements in the treatment of patients. Today we are going to see about the biology of tooth movement, the introduction. Introduction on tooth movement is a complex biomechanical process which is initiated by the clinician with the application of a force. The applied force moves the tooth beyond its range of physiologic tooth movement, which occurs during various functions of the stomatognathing system. Going to the deep dive into the orthodontic tooth movement, orthodontic treatment is based on the principle that if prolonged pressure is applied on the tooth, tooth movement will occur as the bone around the tooth remodels. Bone is selectively removed in some areas and added in other areas. You can see the movement of force is applied in one area and you can see the resorption occurs in another area, whereas bone addition is happening in the tension zone. Okay, going to in the essence, the tooth moves through the bone carrying its attachment apparatus with it as the socket of the tooth migrates. Because the bony response is mediated by the periodontal ligament, tooth movement is primarily a periodontal ligament phenomenon. Forces applied to the teeth can also affect the pattern of bone apposition and resorption at sites distant from the teeth, particularly sutures of the maxilla and bony surfaces on both sides of the temporomandibular joint. Thus, the biological response to orthodontic therapy includes not only the response of the periodontal ligament but also the response of growing areas distant from the dentition. What is physiologic tooth movement? Physiologic tooth movement is nothing but the eruption where after the development of teeth, from them to become functional, considerable movement is required to bring them to the occlusal plane. That is divided into pre-eruptive tooth movement, eruptive tooth movement. Pre-eruptive tooth movement is nothing but made by deciduous and permanent tooth germs within tissues of the jaw before they begin to grow or erupt. These movements are thought of as the means by which the teeth are placed in a position within the jaw for eruptive movement. Analysis reveals that they result as a combination of two factors. What are the two factors? Total bodily movement of the tooth germ and the growth, in which one part of the tooth germ remains fixed within the rest continues to grow, leading to a change in the center of tooth germ. Eruptive tooth movement brings about axial and occlusal movement of the tooth from its developmental position within the jaw to its final position in the occlusal plane. Rate of tooth eruption varies depending on the tooth location, average of 1 to 10 micron meter per day during the intraosseous phase. 75 micron meters per day once the tooth escapes from its bony cell persists till the tooth reaches the occlusal plane. Orthodontic and orthopedic tooth movement are nothing but which lies between the range of 50 and 300 gram, capable of inducing movement of a tooth or a group of teeth in the alveolus. Forces normally higher than 300 grams are called orthopedic forces, whereas conventionally forces measured in grams are denoted orthodontic forces and those measured in pounds are orthopedic forces in nature. Orthopedic forces are capable of generating alteration in the bony configuration either by inhibiting or redirecting the growth or by its enhancing the growth structures. Orthopedic redirection and inhibition of the growth of maxilla are therapeutic needs in children with skeletal class 2 relation or skeletal class 3 relation. The growth enhancement is needed in skeletal class 2 children, what is called functional jaw orthopedics. Bone is a dynamic organ where a lifelong continuous remodeling process takes place by osteoclasts and osteoblasts. The mechanical stimuli are known to alter the remodeling process and are primarily considered as osteogenic. Orthodontic tooth movement requires a remodeling of the bone through the periodontal suspension where forces or mechanical stimuli are generated or transmitted through the tooth. Orthodontic tooth movement involves remodeling of all components of the periodontal ligament, that is alveolar bone, gingiva and periodontal ligament, and to some extent the cementum. You could see the cementum You can see the cementum, the periodontal fibers, your gingiva, your keratinized epithelium, that is the alveolar bone, and your tooth structure, and your gingiva followed by the keratinized epithelium, and the fibers are seen as a tooth and the supporting structures. Tooth supporting tissues. During tooth movement, changes in the periodontium occur depending upon the magnitude, direction and force applied as well as the age of the orthodontically treated patient. Tooth movement is a completed process requiring changes in the gingiva, periodontal ligament, root cementum and alveolar bone with their differences in cell population and remodeling capacity. Periodontal ligament structure and function. Each tooth is attached to and separated from the adjacent alveolar bone by heavy collagenous supporting structure, the periodontal ligament. The periodontal ligament is nothing but the ligament which is surrounding the tooth with the separation from the each tooth from the alveolar crest. And under normal circumstances, the PDL occupies a space approximately 0.5 mm width around all parts of the root structure. Major components of the ligament is a network of parallel collagenous fibers inserting into the cementum of the root surface on one side and into a relatively dense bony palate, the lamina dura on the other side. These supporting structures run at an angle attaching farther apically on the tooth than on the adjacent alveolar bone. This arrangement resists the displacement of the tooth expected during normal function. The orientation of the collagen fiber bundles alter continuously during tooth eruption. When the tooth has reached contact in occlusion and is functionally proper, they associate with the following well-oriented groups such as the alveolar crest fibers, horizontal fibers, oblique fibers, apical and interradicular fibers. Although most of this PDL space is taken up with the collagen fiber bundles that constitute the ligamentous attachment, two other major components of the ligament must be considered. They are nothing but the cellular elements and the tissue fluids. Both play an important role in normal function and in making orthodontic tooth movements possible. The principal cellular elements in the PDL are undifferentiated mesenchymal cells and their progeny in the form of fibroblasts and osteoblasts. The collagen of the ligament is constantly being remodeled and renewed during normal function. Whenever you bite or chew, your function of the tooth is just acting as a suspension, like it moves a little bit, like constantly being remodeled and renewed. The same cells can serve as both fibroblasts, producing new collagenous matrix materials, and fibroclasts, destroying previous produced collagen. Remodeling and recontouring of bony socket and cementum of the root is also constantly being carried out through a smaller scale as a response to normal function. Fibroblasts in the PDL have properties similar to osteoclasts, and new bone probably is formed by osteoblasts that differentiated from the local cellular phenomenon population. Bone and cementum are removed by specialized osteoclasts and cementoclasts respectively. These multinucleated giant cells are quite different from the osteoblasts and cementoblasts that produce bone and cementum. Despite years of investigation, their origin remains controversial. Most are hematogenous in nature. Some may be derived from stem cells found in the local area, that is localized stem cells. Although the PDL is not highly vascular, it contains blood vessels and cells from the vascular system. Never endings are also found within the ligament associated with perception of pain and pressure and positional information, that is proprioception. PDL space filled with fluid derived from the vascular system could be a description of a shock absorber as well. Response to normal function. As I told you earlier, during the masticatory function, the teeth and the periodontal structures are subjected to have an intermittent forces acting upon it. Tooth contacts last for 1 second or less. Forces are quite heavy, ranging from 1 to 2 kgs, while soft substances are chewed and up to such as 50 kg against a resistant object. Quick displacement of the tooth within the PDL space is prevented by the incompressible tissue fluid. The body of the mandible bends as the mouth is opened and closed even without heavy masticatory loads. In heavy function, individual teeth are slightly displaced as the bone of the alveolar process bends, and bending stresses are transmitted over considerable distances. Bone bending in response to normal function generates piezoelectric signals that appear to be an important stimuli to skeletal regeneration and repair. Going to the most important thing of your signals, and very little of the fluid within the PDL space is squeezed out during the first second of the pressure application. If pressure is against a tooth is maintained, fluid is rapidly expressed and the tooth displays within the PDL space, compressing the ligament itself against the adjacent bone. Pain is normally felt after 3 to 5 seconds of heavy force application, indicating the fluids are expressed and crushing pressure is applied against the PDL in this amount of time. Although the PDL is beautifully adapted to resist forces of short duration, it rapidly loses its adaptive capability as the tissue fluids are squeezed out of its confined area. Orthodontic tooth movement is made possible by the application of prolonged forces. If you have a friend or yourself being treated by orthodontic appliances, you might feel the pressure and the pain which is being given on the day of activation. Natural environment forces from the lip, cheek or tongue causes the teeth to move to a different location. Role of periodontal ligament in eruption and stabilization of the teeth. The phenomenon of tooth eruption makes it plain that forces generated within the PDL itself can produce tooth movement. This process continues, although at a reduced rate, into adult life. The continuing presence of this mechanism indicates that it may produce not only eruption of the teeth under appropriate circumstances, but also active stabilization of the teeth against prolonged force of magnitude. You can see the lip pressure being applied on the teeth, whereas your tongue pressure is being applied on the teeth. That is about 5 grams and 10 grams. It could be more than 5 or 10 grams in case of your tongue is a macroglossic tongue. Your teeth pressure gives this lip pressure gives the teeth a movement that is being stabilized by these resting pressures. Okay, periodontal ligament and bone response to sustained force. The response to a sustained force against the teeth is a function of force magnitude. This phenomenon is nothing but the undermining resorption of the alveolar bone near the affected teeth. These cellular elements within the PDL, and this phenomenon is called undermining resorption. Lighter forces are compatible with survival of cells within the PDL and remodeling of tooth socket by a relatively painless frontal resorption of the tooth socket. Going to the terminologies, frontal resorption is nothing but the osteoclasts are derived from local population, while others are brought from distant areas through blood supply. The activated osteoclasts start the resorption process by attacking the adjacent lamina dura, removing bone in the process. Resorption is nothing but a process of removing bone from the cells. Okay, removing bone cells on the adjacent area. Undermining resorption. Once hyalinization occurs in PDL, frontal resorption is not possible. After a gap of few days, the hyalinized zone will be invaded by the cells from the adjacent normal areas of PDL. Along with that, osteoclasts also begin to appear in the adjacent bone marrow spaces. They initiate resorption from the underside of the bone adjacent to the hyalinized PDL zone. Hyalinization is nothing but when you give more pressure, there is a collagen formation, and these tags appear to be like a very common process where you can't move the teeth. Then your osteoclast invade into it from the adjacent cells, and it destroys the bone underneath the adjacent side. Hyalinization. With forces well beyond the capillary pressure level, the PDL is compressed so severely at the site of pressure that hemorrhage, stasis and necrosis set in. Cell die instead of proliferating. As I told you earlier, if it is beyond the capillary pressure level, it compresses the PDL and it gives hemorrhage, stasis and necrosis, where the cells die instead of growing. It is because the cells get necrosed. When the forces increase more than the capillary pressure, the blood vessels get compressed or occluded. The blood supply to the area of the compressed PDL is cut off. The compressed PDL, the blood supply will be cut off. When this happens, the cells that normally get stimulated into osteoclasts do not get activated. Instead, an area of sterile necrosis is seen in the compressed area. When seen under a microscope, the histological appearance will be that of an area without any cells, devoid of cells. and such an area is called as hyalinized zone, and the process is called hyalinization. Going to the most important topic of today is the orthodontic tooth movement. The orthodontic tooth movement is divided into initial period, that is undermining resorption, and secondary period, which is known as frontal resorption. These has three phases of degeneration, elimination of destroyed tissue, and new tissue attachment established. When you give an initial application of force, this is a flow chart which you will be very much happy to learn as a flow diagram. Initial application of force, compression in the limited area of the membrane, vascular circulation and cell differentiation happens at the area of your blood supply, and degradation of the cells and vascular structures. Glassy appearing sterile necrotic area limited to 1 or 2 mm in diameter is known as hyalinization. This occlusion of blood supply happens in your degradation of the cells and vascular structures. The degeneration is nothing but it starts where the pressure is highest being recorded and the narrowing of the membrane is most pronounced. Retardation of blood flow, degradation of cells and cellular changes occur. Swelling of mitochondria and reticulum and rupture of cytoplasmic membrane, leaving only isolated nuclei between the fibrous elements. First indication of hyalinization is the rupture of cytoplasmic membrane. Mild inflammation is observed. Tooth movement stops until the adjacent alveolar bone has been resorbed, hyalinized structures removed and the area repopulated by cells. Elimination of destroyed tissues, adjacent undamaged areas give rise to the osteoclasts, which cause remodeling of the bone on the peripheral areas. Invasion of hyalinized areas by the cellular elements gives cellular elements invade because they have to give blood supply to that area. Adjacent alveolar bone is removed by undermining resorption. Establishment of new attachment is nothing but the re-establishment of the attachment in the hyalinized area starts by synthesis of new tissue elements once the hyalinized tissue is removed. This in turn gives rise to the tooth movement to occur in a natural phenomena. Secondary phase, where your tooth movement occurring after hyalinization is termed as secondary period. Osteoclasts differentiate and cause frontal resorption, deposition of new bone on tension side, that is known as the osteoblast. Bone formation will be done by osteoblast. New bone is deposited until the width of the membrane has returned to normal limits. You can see the undermining resorption which occurs 1 to 3 days in the initial period of force being applied, and this is the undermining resorption which takes around 2 to 10 weeks, and the frontal resorption which takes around after the 10th week. This is the process by which the tooth displays when the force is applied. Phases of tooth movement is another important topic. Burston suggested 3 phases of tooth movement by plotting the rates of tooth movements against time. This is the time and the tooth movement which is being plotted in a graph. This is the initial phase, lag phase and post lag phase. The students must know these 3 phases, that is initial phase, lag phase and post lag phase are the phases of tooth movement. The initial phase is characterized by rapid movement immediately after the application of force to the tooth. This rate is due to the displacement of tooth in the periodontal ligament. Immediately after the initial phase, there is a lag period with relatively low rates of tooth movement or no displacement. It has been suggested that lag is produced by hyalinization of the PDL in area of compression zones. No further tooth movement occurs until cells complete removal of necrotic tissue. As I already told about this removal of necrotic tissues and the hyalinization process, this lag phase will be a very smooth lag period with relatively low rates of tooth movement happening around. And post lag phase is nothing but after the removal of necrotic tissue, the third phase of tooth movement follows the lag period during which the rate of tooth movement gradually increases to a suddenly good amount of tooth movement which is happening. Study by Pylon et al. Performed on beagles divided the curve of tooth movement into 4 phases. That is, first phase lasts 24 hours to 2 days and represents the initial movement of tooth inside its bony socket. It is followed by the secondary phase, which occurs around 20 to 30 days after the removal of necrotic tissue found during the second phase. Tooth movement is accelerated in the third phase and continues to the fourth linear phase. The third and fourth phase comprises most of the tooth movement during orthodontic tooth movement to occur. Optimal orthodontic forces. What is optimal orthodontic forces? Optimal orthodontic forces are nothing but the forces which is in a restricted and it is normal to give for the tooth movement to happen. This is known as optimum, that is optimum level of tooth movement. The optimum force is the force leading to change in the tissue pressure that is approximated through the capillary vessels, the blood pressure, thus preventing their occlusion in the compressed periodontal ligament. The compression or occlusion should not happen for an optimum tooth movement to occur. The capillary pressure is 20 to 25 gram per centimeter square of the root surface area. Optimum orthodontic force should produce fast tooth movement without any harmful effects to the tooth and its supporting tissues with least discomfort to the patient. The optimal force values arise according to the root surface area and the type of tooth movement. Light and heavy forces. It is generally accepted that light forces produce favorable tooth movement by frontal resorption, whereas various studies demonstrated the teeth subjected to high forces show hyalinization more often the teeth experiencing light forces. So light forces produce good tooth displacement, whereas heavy forces produce very low quality of tooth displacement. When heavy forces are applied, periodontal ligament and cells undergo cellular death. The bone resorption starts at a distant site extending towards tooth. Once tooth movement has started, after the second phase, bone remodeling takes place at a certain rate, independent of force magnitude. But maintaining light forces avoid deleterious effects of tooth movement to a large level with less discomfort to the patient as well. In order to produce orthodontic tooth movement, force should be sustained for a considerable percentage of time. Successful tooth movement requires a threshold of force duration of about 6 hours per day. Force magnitude decreases as the teeth moves and there is a decline from the desired force level between two patient appointments. This is called as force decay. Types of force based on magnitude and force decay. There are 3 types of forces, which is continuous force, interrupted force and intermittent force. Orthodontic forces are classified as continuous, interrupted and intermittent forces. Continuous forces is nothing but there will be a continuation of force. It will start at one point, it will go on till your force has been given. Or the interrupted forces is nothing but it will start in one point and it will go, stop, and it will start again, it will stop and it will start again. This is known as interrupted forces. Whereas intermittent forces is like it will start, it will go, it will have a break for some time and then it will start, it will go. This is known as intermittent forces. This is fall to zero when the appliance is removed and it also shows force decay with tooth movement. Intermittent forces acts as an impulse for short periods with a series of interruptions. Interruptions and intermittent are the same. Okay. This is the intermittent force, interrupted force and intermittent force. This is the continuous force. Fixed appliances produce continuous and interrupted forces. Light continuous forces produce efficient tooth movement with least harmful effects to the patient as well. Heavy forces are physiologically acceptable if they act as interrupted ones with a rest period in between. Light continuous and heavy interrupted forces are clinically acceptable, whereas heavy continuous forces should be avoided. Pain and mobility with two orthodontic appliances. Usually it is painful and slightly mobility of teeth occurs in orthodontic tooth movement. Tooth movement is associated with remodeling of adjacent bone, reorganization of the PDL, and so mobility occurs. The heavier is the force, greater is the mobility. Pain associated with orthodontic tooth movement is due to the compression of PDL and associated tissue damage. Heavy forces produce immediate pain after activation. Light forces produces little discomfort immediately after appliance activation. Mild aching pain in teeth and tooth sensitivity to pressure is commonly noted for the first 2 to 4 days. Theories of tooth movement. We know we have different theories of tooth movement. We have bioelectric theory, fluid dynamic theory and pressure tension theory. The bioelectric theory by Farrar in 1876 relates tooth movement to change in bone metabolism controlled by the electric signals that are produced when the alveolar bone flexes and bends. Piezoelectricity phenomenon observed in many of the crystalline materials in which a deformation of the crystal structure produces a flow of current as electrons are displaced from one part to the crystal lattice to the another. Characteristics of piezoelectric signals. These are due to migration of electrons within the crystal lattice and it is distorted by pressure. Electrons migrate from one location to the other and an electric current is observed. Crystal is stable as long as the force is maintained. When force is released, the crystal returns its original shape and a reverse flow of electrons is seen. Hence, a rhythmic activity would produce a constant interplay of electric signals, whereas occasional application and release of force would produce only occasional electric signals. There is also a reverse piezoelectric effect not only on the application of force cause distortion of crystalline structure, and it is within an electrical signal application of an electrical field can cause a crystal to deform and produce force. The fluid dynamic theory given by BN in 1966, also called as blood flow theory. Tooth movement occurs as a result of alteration in fluid dynamics in periodontal ligament. Periodontal space is a confined space and a passage of fluid in and out of this space is limited. A hydrodynamic condition is created that resembles a hydraulic mechanism and a shock absorber. You could see the tooth structure. The root is being surrounded by the PDL which acts as the shock absorber. Shock absorber which is the resembles a hydraulic mechanism and a shock absorber for the tooth. On application of force, the squeeze film effect results. On application of orthodontic force, blood vessels get trapped between principal fibers and stenosis results. Vessels above stenosis balloon resulting in formation of a aneurysm. When a blood flow is being given pressure and it is stopped, it will be forming stenosis. These can act as a minute springs between tooth and bone, helping in replenishing squeeze film, dissipate the applied force. There is alteration in the chemical environment at the site of vascular stenosis. This results in reduced oxygen level on the compression side, escaping of blood gases into interstitial fluid, creating a favorable environment for resorption to happen. Pressure tension theory. This is nothing but a classic hypothesis on the mechanism of tooth movement based on the work of Oppenheim and Schwarz in the year 1911 and 1932, relies on chemical rather than electric signals as a stimulus for cell differentiation. Most accepted theory of tooth movement, this is the pressure tension theory. Sustained pressure causes a tooth to shift position within the padial space. Some areas of the ligament get stressed, some compressed, but blood flow decreases in the compressed area and increases on the other side in the areas under tension. Blood flow alteration leads to quick changes in the chemical environment, example reduced oxygen level in the compressed region. These chemical changes act either directly or by stimulating the release of other biologically active agents that stimulate cellular differentiation and activity. Thank you so much for your patient listening and all the best. Thank you.